So office microbiology. The problem in the office is that you're not given the help you need. And again, it's going to be, I don't want to send you off on a sad day, but I'm going to tell you where the pitfalls are, because it'll help you better understand when the patient doesn't get better or something happens, you don't get the result, why you're not getting a result. I do the research for all these companies. Again, there's so few of us infectious disease people that have time to do research and funding to do research. So most of the diagnostic companies I work for, again, this is going to be the secrets. You know, they're not really secrets that just no one, you know, the journals don't want to just hear editorials about why things are bad. So this is my secret bunker and all the things I'm going to tell you. They're not so secret. The problem is you get mandated to do things. For OB, you're told you have to do group B strep, which they do a pretty good job at. Gonorrhea, chlamydia, we'll talk about that. Hepatitis B is okay. Syphilis, we've worked on it. HIV, urinary, UAs and cultures, and Pap tests. For OB, you're officially told by the Preventative Task Force we mentioned earlier and the CDC, gonorrhea under 25 if you're at risk factors, chlamydia for everybody under 25, Pap tests, HIVs, HIV and screen for BV for some GYN procedures. Again, in that cervicitis part of the CDC guidelines, it's if you're going to do a procedure, you can do a procedure without prophylaxis and a patient's not infected. Well, you don't know they're infected unless you screen for them, but they intentionally make it vague so you don't get sued all the time for things. Herpes in micro is a mess. Okay, herpes is a big problem. There's more HPV than everything else because you get it and you keep it. But per year, there's more new cases of herpes. With HPV gets cleared, but herpes doesn't. The few million this year that get herpes stay on for next year and next year and next year, and it adds. So there's lots of herpes. There's a test question about incidence and prevalence, about which is the most prevalent STD. Again, just because they have a low number that you don't see and it's asymptomatic doesn't mean they're not infectious. So testing is important. And there are specific tests. Again, straight out of the CDC, there are specific tests. Glycoprotein G2 for HSV1 and G1 for HSV1. The names of the tests are here. They're in your handouts. They're in the CDC document. These tests are very, very good. The problem is these are not the only tests on the market. That's why these are specific. So CAP, College of American Pathology, when we have a lab, that lab has to be certified for every diagnosis, every bug that we want to fix. We've got to submit to the CAP, and the CAP sends us unknowns a couple times a year. So we're shown that we're a reasonable lab. So it's hard. And I have a lab still. I maintain a lab still in Oklahoma, and we go through these testing. They looked at 172 labs, and they send out samples, and they do this all the time, that were HSV1 positive and HSV2 negative. And what they found is that they were right 99% of the time for HSV1, but 50% of the patients found that said there was HSV2 there. So you have a patient, 90% of your patients at HSV1 cold source. This is their bloodstream. They're all going to be positive, which is good, but they accurately determine that. But 50% of patients didn't have HSV2. They said that patient had HSV2. Okay, it's 50. Now, that's because that's just 172 random labs. There are labs that did the good test and labs that did the bad test. The good test costs about $13 for the lab to do. They get reimbursed $48, $49 from Medicaid, Medicare. They make a nice profit margin, but they're greedy. They want to make more profit. So they use the $5 test instead of the $13 test. And what they showed, if you use the glycoprotein G assay test, which were $13 a test to the lab, they were 100% correct. But you can save a lot of money if you're doing 100,000. If you're a big lab doing 100,000 HSV tests a year, you use the $5 test. You just made $1 million or hundreds of thousands of dollars. They were 88% wrong. Okay, so overall, there's a 50% chance that HSV2 you tell your patient you have HSV2. She doesn't have HSV2. So just realize that. What you need to do, unfortunately, is we need to take an extra step, and it's unfortunate. You need to go back and say, what test do you do? I go to the point where I say, what test, it should be on the report, what test is done. And as you start looking at your reports, you'll see that a lot of them don't even use approved tests. They self-validate. They do their own test internally. And if they do a test that's based off the non-glycoprotein G, Again, they're going to be wrong 88% of the time, but it doesn't matter. The FDA allows them to do it. The test is approved. They get away with it. The FDA is really trying very hard. They go back and they look at these tests and they take them off the market. They've taken the Abbott Chlamydia test off the market. They're taking different tests off the market. But it's a lot of work for them. They don't have a lot of support, and they're going to have less support in the future with the way the economy is. Chlamydia and gonorrhea, the things that you look at most often in your office, okay? Guidelines, screen under 25. If you're do a risk assessment, multiple partners. And again, the one good thing is they say don't do a test to cure because azithromycin and doxycycline are so good, but test them 3 to 4 months after treatment, not for a test to cure, but to see if they're reinfected. Okay, it could be 6 months, but it's supposed to say 3 or 4 months. Now, culture for chlamydia and gonorrhea are very similar. There's culture, and that's what we used to do for the standard of care. And just a couple of years ago, it's changed over to the NAT, nucleic acid amplification test, the DNA test. The culture is tough because it's a special media you have to have available. You got to get the specimen, you got to put it in a collector, a cup of ice, and get that to the lab before it melts, and get that before Friday because they're not going to run it over the weekend. Then they have special media and special tissue cultures they have to grow it on. Very hard to do. It dries out. It gets wet. It gets warm. You lose 20%. Not very sensitive, but the best way for chlamydia. It's gone by the wayside. You'll not see that anymore because there's no issue with, it's not a bacteria, there's no issue with sensitivity. It'll be different with gonorrhea. 3 main tests they use. Again, Abbott was the 4th, it's not there anymore. GenProbe Aptima, the Roche Amplicor, the original DNA test, and the BD ProTech. You're not seeing a lot of Roche because Roche, the interesting story is when everybody's worried about the avian flu and the flu epidemics, they make Tamiflu, and they were told that it's such a big crisis and the government needs more Tamiflu that they're going to violate their patent and have other companies make Tamiflu for the federal stockpile. Roche said, we don't care, don't violate our patent, we will stop every other part of our company and take all our resources and make enough Tamiflu for you. So they stopped doing the Amplicor development and testing for a while. They're now picked that back up, so you'll see some of those tests. But the best way for a test to get working with the 2 big companies, Quest and DLO, is to tell them, fine, we'll only charge you $10 for the test or $15 for the test instead of $15 or $20 or $25 or $27. We want their business back. So they'll find the cheaper test. The 2 cheaper tests are now Roche and BD ProTech. Okay, gonorrhea, very quickly. A little bit of penicillin, tetracycline, lots of resistance. No resistance yet, although they're just starting to see this MICs go up. And the same thing happened with the quinolones, with Cipro. And it took about 3 to 5 years, and they think in about 3 to 5 years there's going to be a problem. The reason I bring this up in testing is that at some point in time over the next couple of years, your recommendations are going to change. And if you have a patient with gonorrhea that gets gonorrhea back, even though you gave her ceftriaxone, which right now they don't care about because there's no resistance to ceftriaxone. So if she gets it back, she's probably been reinfected. At some point in time, we're going to see this. They got gonorrhea back in 3 or 6 months, not because they got reinfected, because of resistance. At that point in time, they're going to ask you to do cultures again because the only way you can test for resistance is to go ahead and get the culture. So just don't totally forget the culture. It still pops up on the test. Again, we tried these courses. When I first started out here, this was kind of a review course for, but you're really not here for a review course. You're here to look at what's new. You're here to find out things that'll help your practice and some interesting things too. So don't forget the culture. That's why the tests you'll have what's chocolate agar, you keep it in carbon dioxide, the Thayer Martin media, that's still around. Okay, so the 3, gonorrhea testing, same thing. Okay, no, it's not. So basically, for my lab when I started in Oklahoma, okay, we have a proposed lab, and they're trying to tell us my lab versus the 2 local labs, the LabCorp and the proposed Planned Parenthood lab. That's where all our STDs were, and the GenPro test. And basically, the problem is when I'm a company and I want to do a test, I go to New Orleans. I go someplace where there's lots of STDs. So if there's a 25% chance of an STD, and I get a positive, if I look at the population, there's a 25% chance that positive's positive because it's there. If your prevalence is low, then your sensitivity and specificity change. And even though my sensitivity is good because I looked at 25%. If your prevalence rate is low, so if your prevalence rate in your population for chlamydia, it's probably 2%. Okay, my highest population is about 7%. Again, in Oklahoma, in New Orleans is 20-something%. But say it's 2%. So if you have a patient that comes in, and you're in New Orleans, there's a 25% chance it's positive because it's 25% prevalence, and versus a 2% chance. If your sensitivity is 96%, that means you'll miss 4%, or your specificity is 98%. That means you're 98% sure that positive is positive, but there's a 2% chance it's a false positive. But there's a 2% chance, so you get a positive. If there's a 2% chance it's a false positive, and the 2% chance, that's what your incidence is, that it's positive in that population, that means 2% versus 2%. There's a 50% chance that that's a correct test. Okay? So in your low prevalence populations, in your high prevalence populations, the chances that it's really true are good. But in your low prevalence populations, it's low. So what I'm telling you is that even for the best tests, the GenProbe, if you are a 2% patient population, again, the average private practice in a suburban community is 2%, and you should know your rate, there's a 50% chance that's a true positive. Okay, 50%. 50%. So when you get this result back and you say, oh, it's DNA, must be right, there's a 50-50 chance that's positive. So you can't tell your patient you've got chlamydia, because the first thing I say is, my husband cheated on me. I get 2 or 3 women a year that come to me. I want a divorce. My husband, this is positive. And I say, listen, first, what kind of test did you have, and what are the chances that it's positive? And then and I still do cultures, and I'll do a culture to prove it's really there, and it's not there. And then I told you the one story. Then their attorney gets mad at me because he thought he had a slam dunk case with a positive thing, and he doesn't. Then the husband's stupid. He doesn't realize the tests aren't good, and he confesses, and he didn't have to because the test was wrong. I've had that happen before. So again, if your prevalence rate goes up 5%, and again, you're not going to see much more than 5 or 10% in your population. It's still only 3 out of 4 or 4 out of 5. Okay, gonorrhea about the same. Okay, so you get a report back that says it's gonorrhea. There's a 30% chance it's a false positive. They don't have gonorrhea. Okay, it's just the way you manipulate the test. You move your sensitivity. The test works by they light up a gene sequence, GC, and they light that up, and then they count the number of dots. And you can decide if you're going to capture more positives, get the better sensitivity, or if you're going to catch less sensitive, be more specific. You can move your number around depending on what test you want. And they manipulate around because the FDA says once you're over 95%, you get approval. Okay? So 95%, again, doesn't help you a lot. So GenProbe is a better test, but it's more expensive, so most of the labs don't do it. Probably half the labs don't do it because they don't really care. Some of them aren't greedy and they look for sensitivity. Here, I think I was able to fix this. Yeah, a little closer. Take a look at the BD Probe Tech, which is getting better. They know they're in trouble. They're losing business. They're losing half the business because people are complaining. I got a lady who's, says she hadn't had sex in a year, and I just sent the gonorrhea and chlamydia off by accident. It comes back positive, and she's not having sex. And they're starting to realize it's not true. So if you're in this patient population, because the test isn't as sensitive, and when your sensitivity is 90% and your specificity is 96%, again, your sensitivity is going to be the same in the entire population. So if you're looking for it, 10% of the time they're not going to find it, which, you're negative. It's not so good because then you go on with chlamydia, but if they have symptoms, you're going to treat them and do something else. But when your specificity is 96%, again, if your prevalence is 2%, that means 2% of the time it's going to be true. 4% of the time it's the sensitivity of the test. So your positive predictive value is 35%. So 65% of the time it's a false positive. So the main thing is when you get your results back, you may ask for the lab test, but 50 versus 65% isn't a big deal. A positive is not a positive is not a positive. It's about 50% chance that positive is a real positive. So for me, this is really a screening test. Then so how do I work with it? I say, listen, if you really want, and I get just the referral. So I get the ones who, I'm leaving my husband unless you can prove this to me, and I want this, and I'll do a culture in them, and it'll come back negative. Or I'll look at their test and say, you don't have a cervix, and chlamydia doesn't live in the vagina. Urethra may be on your urine, but it's not in the cervix. But I'll basically, counsel them, and I'll do a culture. But for you, you just need to say, You know, it's a 50% chance. They may say to you, well, my husband has been cheating on me. I didn't want to get into the whole, thing about the divorce and stuff like that. And you treat her. You have to retest her. The official policy by the FDA and the CDC is you do another test, another NAT. If you can't get a culture, and most of you can't, you do another NAT to do a different one. If you have to ask for one, get the GenProbe one. So for your offices, if you have labs, you got Quest and DLO and everything are different insurances, and it's hard. And again, they're making it harder on you, but you want to take care of your patients. And if they really want to know they have gonorrhea and chlamydia or not, then you go ahead and you do a different NAT. So you just go to the lab at a different NAT, or you go to those other labs, the MDL or the Biopath, and ask them what they use. And I think most of them are using the GenPack. And if you do a second test, then you get it up to like 90% accuracy instead of 50%, because the chances that it's wrong twice are 50 on top of 50 or 75 on top of 50, and so you get most of them. But that's the main thing. Gonorrhea and chlamydia, when you get them back, are not always positive. 50% are wrong. Gonorrhea is less. Again, still, gonorrhea in your prevalence is not over a half a percent, 1%, unless you're working in an STD clinic or an indigent clinic. It's not going to be over 2%. So again, you can see 40% of the time, 20% of the time, 40% of the time, 50% of the time, it's a false positive. Okay, so don't worry about it. Again, you're not going to do a lot of this, but I just want you to remember real quick, rectum or pharyngeal. She says, I have oral sex. You want to do pharyngeal test. Again, 50% of the time you're going to pick it up. So you can't say, oh, gee, I did a pharyngeal swab. None of them are recommended pharyngeal. There's too many conflicting bacteria. You've got all these other bacteria with genetic sequences that are very similar, especially for Neisseria gonorrhea. There are other Neisserias that aren't gonorrhea. And what happens is you get false positives, and you also, they dummy down the thing and make sure that you're more specific, because they don't want a false positive gonorrhea, but your sensitivity goes down. And it's only 50% for the cultures and the PCR. This is the Roche test. The strand displacement is the ProbeTech, BD ProbeTech, and TMA that's the GenProbe. The TMA is the Aptima. So again, different sensitivities based on what test you got. And again, just over and over, culture is low, but still 30, 40, 50% of the time you're missing them on non-genital sites. Okay, same thing, 25% of the time. So a negative is not always negative, a positive is not always a positive. Just remember that in your back of your head, especially when the patient says, or you're telling your patient they have an STD, because there's a 50% chance they don't have that STD. Okay, so those are the things. Liquid Pap, you can take them off the Pap smear. Again, sensitivity and specificity. When you get 92% specificity, that means your prevalence has to be 8% in your population for you to have a 50-50 chance. So when you do the Pap smears, and that's because in the ThinPrep and the SurePath file, there's methanol and ethanol. And what they do is the methanol breaks down those strands smaller and smaller, so you wind up having some segments light up that really aren't chlamydia and gonorrhea. Again, SurePath is a little worse, about 15%. Again, just remember, you're going to miss more. Your specificity is good. So what they did is that we want your specificity to be good. We don't want false positives, but you're going to miss 15%. So if a patient that comes back high risk, you got a SurePath, you're doing the CT on it, comes back negative, and say, gee, I had that mucopus. I'm pretty certain it was chlamydia. Surprise, it's negative. It's negative because 15% chances it's negative because you missed it. And I again treat them clinically. And they just in the back of your mind know that their DNA is not this is not O.J. Simpson trial. The DNA is not the DNA is not the DNA. Trichomonas we talked about before. It's an issue. The FDA thinks it's important. Again, we look at our differences. When I'm a company, I go to a city with a high prevalence rate because that artificially inflates my positive predictive value and negative predictive value. Okay, so Trichomonas, go to New Orleans. Most things you go to New Orleans. I tease people when I would go to ACOG and go to different meetings, is that the commercials at Las Vegas goes to Las Vegas, stays in Las Vegas. For New Orleans, what goes to New Orleans comes home with you. Okay, and it's a high herpes rate also. But you can see different places of where you've been. But let's see, most of the places, even in New York, your GC, your chlamydia rate's 6%. In Oklahoma City, 7%. New Orleans is good. If you live in New Orleans, I feel bad, but because the lecture doesn't apply to you because you're in a whole different category. But in most places, it's low. Even New York City, it's low 6%. So most of those false positives, both those tests are going to be false positives. GC, it's except in New Orleans, it's under 1%. So it's all 50%. Okay, Trick. Lots of questions about Trick. I see Trick. There's more and more cultures out there. Cultures came back because they were testing all these new tests, and I'll show you the new test results in a second. Wet mount, when you just get Trick, there's not a lot of Trick. I see patients with lots of white cells, and I say, I'm pretty certain she has Trick, and I knew she had Trick before, and I've got to look around for a while to find it, and I maybe can find it 90% of the time. I thought I was, perfect, 99%. I miss it 10% of the time, and I love to look at slides. Pap smears, the pathologists are looking for dysplasia. And a lot of the pap smears are automated. And they don't move, when they're on the pap smear slide. So they don't pick it up. If they happen to see it and they see the nice flagella, they'll report it. They report it about 50 to 60% of the time there. So if you think you see it, or the patient says her boyfriend has it, and you look under the, and your pap smear from that this week or next week, or you do a pap smear, don't rely on the pap smear. It's going to miss it. There's some office tests that are pretty good, and your BD Affirm, as we mentioned earlier, is pretty good. But there's, again, a study looking at putting that in from the pap smear, getting it from the pap smear vial, or for looking at the new nucleic acid test. And basically, when you looked at, in Baltimore, a prevalence rate of about 15%, which is high, your specificity was very, very good. Okay? The gold standard for bacterial vaginosis is your AMCELS criteria. The FDA, for all the studies and for anything we're looking at for research projects, is the gram stain, which I like to do. For you mentioned earlier, BD Affirm looks for Gardnerella. I don't think there's any normal Gardnerella. I think Gardnerella is a BV infection waiting to happen. The PCRs that just came out, and the PCRs, again, 98 to 99% sensitive, specific, and do fine. You're able now to check with your lab saying, I see white cells, or I suspect inflammation. I want my pap smear. I want my gonorrhea. I want my chlamydia. I want my Trick test. They're working on this year. We're going to be starting a test for BV. Again, it's just hard because you're going to have to pick a marker. And the question is, Hopkins is voting for Mycoplasma genitalium. We're still voting for Gardnerella, since we're from Texas originally. And that's the decision on what's going to be the marker organism. But we'll get there also. Normal slide, remember I showed you before, lots of white cells, okay? Okay, you look at that. That's the group B strep we talked about before. You'll get the group B strep. You may get normal vaginal flora, but again, you see something abnormal. Your micro lab is not there to help you. They're there to make money, okay? They're very rarely there to help you, unless you know the microbiologist, which I know the microbiologist. He doesn't like me, but I bug him every single day about something. I said, this patient traveled from Colorado. Don't screw this lab up. And they still screw the labs up 10% of the time, okay? So the group B strep, that's generally fine. They are now going to report to you in your laboratory if they find group A or group G strep. The reason is group A, 2 patients died, and the lab, when they screened, reported out, that they had group B strep, but they didn't report group A strep because that's not what they were looking for, even though they found it. They want to make you order it so they can make money off of it, but if they saw it and you didn't order it, they're not going to report it. Well, 2 of those patients died. They said, you knew it was there. Stick it on the report. Don't just say it's just, it wasn't there. And so the 2 lawsuits, the lab lost those lawsuits, and they got to pay millions of dollars. So now there's also group G is popping up, probably only 1 out of 300 patients. Group G acts like group A. And so you're going to see reports now that say group A and group G. You see group A, you got to do something about it, okay? So for your lab, they're trying to protect themselves, kind of like the radiologists. You got a mammogram, there's nothing there, but that doesn't circumvent your physical diagnosis and that kind of stuff. They try to, all these disclaimers. There's a disclaimer on almost every one of your micro tests. The micro people are notorious for this. Okay, yeast. Again, we talked about yeast before, Laudatorilopsis glabrata. I'm telling you, you're not getting, and because of the diflucan we talked about before, the sensitivities, they don't give you sensitivities. If they do give you sensitivities, They only give you the sensitivities to the IV drugs because the sensitivities are being ordered by the transplant doctors and the AIDS doctors who want to know they're going to keep all the AIDS patients are on persistent diflucan, and if diflucan is resistant, they go to intraconazole, and there's new drugs going out. So they don't care about your vaginitis patient, so you won't see the sensitivities. So if you ask for sensitivities and it costs extra money for the patient, unless you're able to select the drugs you want, you're not going to get a drug you're going to use. Okay. The other thing is, when you get this, they don't pick this up. Depending upon the lab, 25 to 100% of the time, they're not going to pick this up. Why? The reason they do this is the test is they get a sample and they have a choice of putting it on a plate, okay, or putting it in germ tube media. It's simple to take the sample and stick it in germ tube media. Germ tube media, then in a day or two, they look at it. And if there's hyphae growing, okay, they report out you have yeast that's growing. If there's no hyphae growing, they don't report, they say the yeast is negative. It's not negative. Torulopsis doesn't make hyphae. So for the lab, I've got to tell them, I want you to specifically look for non-albicans strains. So you have to, if you want to look for Torulopsis glabrata, you got to ask your lab, are you looking for non-albican strains? Let's say, no, we just do germ tube media. Then they'll never find it. Because they're looking for germ tube media where it looks for germ tubes, and when they see the cells forming hyphae, then they'll report back positive. So they won't do this. So I have a lab saying, I want you to grow it on a plate, take those colonies off a plate. You then can use a germ tube to tell me if it's kind of albicans and non-albicans. If it's non-albicans, I want you to further grow it and speciate it. Well, what happens is they do that. But how many reports you get? My patients know it's 5 weeks to get your result. If you're not taking 5 weeks to get your result, they're not doing the right test. They're just giving you a germ tube media. I sent this off April 9th. May 5th is when I get the report. Anything, 10 days, 5 days, 2 days later, they're not doing the right. You're not getting, there's no way you can get non-albican strains. Okay, so when you say, gee, I saw those funny cells that Mark told me about, and she's not responding to, she was on diflucan for a long time, and she's not responding to antifungals, but it seems like it's yeast infection. She's itching. She's got that cottage cheese discharge, but my report came back, last week that said there's no yeast there. She may be the chronic intermittent yeast, but unless they're waiting a month, they're not doing the test right. So again, perils of microbiology. So that's it. I just wanted to go for quickly to just 4 or 5 points for you to know. The main point is, the microbiology laboratory is not there to help you. They're there to make money, and they have to keep the insurance companies happy. The insurance companies go to them and saying, we'll give you all our business if you can come in at this price range. And then they have to say, we come in this price range, where are we going to skimp? They skimp on vaginitis. They skimp on vaginal cultures. They skimp on some other things. They're not going to skimp on bacterial blood cultures. Okay? They're not going to skimp on MRSA, because if they miss that, they get in big trouble. But they out of the way. And I used to go to Congress twice a year to fight for this stuff. And all they did is they said it's not important. It's not important. It just got me so mad. So next year, when I get the website going, you will have sandpaper underwear for men. And so when the woman tells you, I've got this problem, the lab was not helping me, you can't, that help me, my husband drive me crazy, say, just tell them that this is important, this is real, we haven't got the diagnosis, have him wear this underwear to see how it feels, and maybe he'll leave you alone. So, because it's really, I don't want to end you off with down. We got nice day tomorrow. This is your last gynecology lecture, but it's really something that's not helping you. And again, there's nothing more sad. Definitely don't let it take out an ovary in a 10-year-old unless you think it's malignant. We have the data. We've got to get the information out there. And don't tell somebody that she's got gonorrhea or chlamydia and you've got this DNA test. Because again, 50, 60, 70, 80% of the time, it's a false positive. And if you want it to, you have to get a culture. Yeah. The question is, what do you do with yeast and pregnancy? It's hard because, the immune system downregulates a little bit, and the cellular immune system downregulates a little bit because the male part of the baby, the reason there's 20, 30, 40% miscarriages, and most of them are early, you don't know about it. Some woman says, gee, I missed my period. I missed my period for 2 weeks, but, I guess I'm just irregular. No, you're not. You had a miscarriage. 50% of the time, it's a miscarriage. But if their immune system doesn't downregulate, then they miscarry. When it downregulates, it doesn't catch the male part of the baby, but it doesn't fight the yeast. And you don't have bactericidal fungicidals like you do with antibiotics and bacteria. You have bactericidal and bacteriostatic antibiotics. Your fungicides are fungistatic. Your fungicides, the ones that really kill, are your things like the gentian violet and stuff like that, which you're not going to use in pregnancy. So it's really going to have to be hard. I don't use Terazol. Terazol, all of them has a little bit of, toxicity and stuff like that. I just basically tell them to use Monostat. I like clotrimazole tablets. Again, they're good. Most pharmacies don't carry it because the clotrimazole tablets also contain lactic acid. So it helps their pH a little bit, and it helps control it a little bit better, maybe 15% better. But it's a hard problem for yeast, and I basically tell them, we'll try you intermittently on a 7-day course of, I like clotrimazole the best, but they're all okay. I'm not as big a fan with Terazol, but I don't have them waste their money on the once weekly Gynosol or things like that where it costs $25 because most of the stuff is over the counter. And some of this, the Gynosol isn't, and they spend all those $25-30 every week to do that. So nice little. I have them start out with clotrimazole, use it for a course, and then I just suppress them for the rest of pregnancy. Just to use it once or twice a week for the rest of the pregnancy. Because what happens is you let them grow back, and it's hard to cure. You let it grow back and hard to cure. Let it grow back and hard to cure. So I just say after it's the second time, I go ahead and just say, just take this once a week, sometimes twice a week, usually just once a week for the rest of pregnancy. So, I mean, I have lots of stories, but that's the answer to your question. Another question? Yeah, I mean, if the PAP sees it, if they see it, and it's a good pathologist, I mean, it could be a crazy pathologist, but if it's a good pathologist, they're seeing flagella, and they're seeing trick, it's there. Again, if the test, it depends what the test they're doing in the laboratory. A lot of laboratories are just doing the VP Affirm or some older test, which is they're doing PCR, and they're gonna miss. There'll be a strain that doesn't have the right strand in there, and they'll miss 1%, 2%, 3%. So, but if you had that choice, I would ask for the slide and look at it myself, but I would trust the pathologist because he's only going to call it if he sees it, okay? And he sees flagella, and patients don't believe it. I have a patient with trick. It's the only time I march the patient over, and I say, "Look at those things moving around. That's Trichomonas." And they go, "Oh, they think it's cute and interesting, but it's not. When you think about it, it's just parasites growing inside them." But when they go home and they tell their husband, "I have Trichomonas. It's a venereal disease. You gave it to me." He goes, "Oh no, the doctor's not right." And she goes, "No, I saw it. And it stopped this guy calling back. How can you tell my wife I gave her a venereal disease? I said, well, she saw it. I mean, for me, the test to cure is just a wet prep. I mean, you can do the PCR now. It's simple to check off. Just get a swab, send it off, or collect a broom or something. You don't want to use a spatula or a cider brush, but some collection or spatula. Stick it in your SurePath or thin prep vial, and you can check it off now and get bored. But that's if you want to do. Either way is fine because test to cure. It's going to most of the time it's going to be whether they took their medicine or not. Yes, ma'am. Yeah, I mean, they're not any. I'm not advocating it. GenProbe is 50% false positive. The Becton Dickinson is 65% false positive. They have a new test out. Becton Dickinson just came out. We did the studies for it, but we haven't had a chance to review the data to see what the false positive, false negative. It's going to be around the same. It all depends upon your prevalence in your population. Because again, even if it's a 1% chance of a false positive, if there's only a 1% chance in your patient population, if it's positive, which is it? Which is it? So, but they're all about the same. I like the GenProbe. You can't tell DLO lab this is what you want. They're going to do what they want. But if it comes back positive and she wants to know for sure, then just find another lab that does the opposite test, and it's usually it's going to be the GenProbe. But it could be the other way around. But again, the main thing is don't tell your patients their marriage is a mess and it's STD, because it's 50% or more it's not. 80% chance it's not. Yeah, and it's hard. But again, sometimes the guy doesn't know that's true, and he just says, "Okay, you caught me," and he tells them. And I said, if you just would have tested yourself, you would have known it was probably negative. It was more likely it's a false positive. But yes, ma'am. Yeah, but your rate's higher. Your rate will be 10-15%. So your positive predictive value is going to be up around 85 to 90%. But even if I suspected it was a false, I'd still treat them because if they're coming in getting tested, I mean they're not coming in maybe for their annual exam, but there is a reason. If they're sexually active, it's $2 worth of doxycycline, as long as she's not pregnant, is a lot easier than retesting twice to see if you're 90% sure. So when your prevalence rate gets over 7 to 10%, then it's just better to, you're 90% sure, but not always. I mean, I just wouldn't bet a marriage on it, and I wouldn't, start a family feud over this test. But your 18-year-old freshman or 19-year-old sophomore that gets a positive, she's going to be more mad at which is the guy, who's the guy, or I'm mad at my boyfriend because who's the girl, than I wonder if the test is positive. Yeah, it's just it's just in that range. I mean, it's a machine. The machine just says from it comes in as 0.0016 light units. It's called light units. You're positive 0.0016 to 18. It's equivocal and higher. So they just can't give you results. It's right in that borderline. So it doesn't really help you. Just they ask you to do it again, and because they want you to do the test again. It's just a technical leeway they can do that. Yeah, the chances it'll be one or the other, and it'll go one way. It's rarely. You don't see a lot of them because it's rarely that it'll stay in that zone. Yeah, but you do a lot of chlamydia and gonorrhea tests probably. I mean, it's going to happen 1-2% of the time.